So, good morning students, you are MBBS 2022 batch, okay, junior final. Okay. So, this is your second class of neurosurgery, in which we are taking the neurological assessment, GCS score and management of traumatic brain injury. Earlier one of my colleague has taken the introductory part of head injury and some biomechanics, I think so. So, in this class we are going to evaluate the neurological assessment in head injury, particularly Glasgow Coma scale, investigation and imaging in head injury and the management. It is a very important topic because not only in your clinical practice, you are going to encounter head injury patients in your further practice, as well as there are many questions that come based on Glasgow Coma scale, and in interviews whenever you go for your MS exam or USMLE, you will be facing question based on the clinical assessment and management of these patients. So, why it's so important? It's so important because globally the incidence is 20 million in a year. 20 million means that's approximately 2 crore, and in India itself, this is 2021 data, 2 million people undergo significant head injury or a traumatic brain injury, and out of that round about 40 to 50% they die. So, this is the annual data, 1 million people die in India because of this, and the number will go on increasing because the number of vehicles are increasing, the number of cities are increasing. More importantly, it is also important that most of these patients, they are young, they are under 40 years of age, and there is a predominance of male in this, young male, because most of the cases of traumatic brain injury is of road traffic accident. But unfortunately, in India there is, please come in. We fail to prevent these injuries because of various reasons, because of the lack of safety measures, because unawareness about the safety measures which can be taken, and these pre-hospital care, poor infrastructure. So, we are not able to provide adequate prevention measures, neither hospital care and post-op rehabilitation. So, that is why out of 3-4 classes of neurosurgery, this topic was selected. We will go for assessment and management side by side, because these things go side by side in the trauma center, and as our institute is an apex trauma center institute, so we provide advanced life trauma support here, which is based on primary survey, secondary survey, but even the pre-hospital care or the basic life support which needs to be given will be covered in the sections. So, this is the pre-hospital or the basic life support, in which initially the patient is stabilized, airway is protected, breathing is checked, and measures are taken for controlling the bleeding. The patient is stabilized with a cervical collar to respected or the nearby trauma centers, and then they will end up in the emergency. So, in emergency, with the staff available there, the ATLS guideline which we usually provide here. That includes control of any severe bleeding from the scalp or any other source, airway management, breathing, circulation, and apart from the basic life support, we also evaluate the disability or the neurological assessment, which is the D, and also exposure, which is followed in some part of the country. So, control of external bleeding, that is very easy. You can put some pack and pressure, apply bandages, and most of the bleeding can be stopped by that maneuver. If that is not helpful, then there are certain staplers or sutures which can be placed over the scalp, which can stop the bleeding and provide temporary measure for the next step of airway protection and cervical spine stabilization. Particularly, we will take up those points which are usually found in traumatic brain injury or head injury patients. If the patient is conscious and he is talking clearly, so most of the time the airway is patent, and you need not to take very aggressive or very immediate intervention for that. But if there is noisy breathing, stridor, pooling of saliva, then you have to clear that secretions by oral suction. You can also give a jaw thrust, put an oral airway, and by this manner you can clear the airway. Even if that is not required, some of those patients, they may require ventilation. If you are suspecting moderate to severe head injury, then in all those patients a high flow oxygen should be provided, and you should search for the other pathologies also, like tension pneumothorax, injury to the chest, so that they can be taken care of simultaneously. For that, you can also apply a oxygen monitor, and the saturation, if it is more than 90, then you can proceed for further control of circulation. In most of the cases, there is loss of blood volume, so there may be hypovolumic shock, there may be other associated injuries, spinal trauma, which can lead to shock. So, a blood pressure monitoring is needed, and a blood pressure of systolic or a mean arterial pressure of 90 is what we try to achieve in an adult trauma patient. In children, that may be low, and for that we can give blood, fluids. Initially the fluids are available, so you can give fluids, preferably the normal saline isotonic fluids. Dextrose and other fluid, they are usually avoided because they increase the cerebral edema later on. Now coming to the main part of neurological assessment, and there are two important things which will be asked by you, in different exams, and as well as you should be knowing about those things. One is GCS and other is pupillary reaction. GCS is the pillar of neurological assessment in traumatic brain injury or head injury, because it is simple, reproducible, and it provides you a universal format for assessment everywhere. In most of the centers, initially the GCS is applied so that the triaging and all those things can be done. Examination of pupil. In pupil, two things again is important. One is the size, whether they are equal. If there is a disparity of more than 4 mm, then it should be seen with suspicion. Usually the normal size is 2 to 4, but more important is the size, which should be equal in symmetry, basically, which should be equal. The second thing to be examined in pupil is the reaction. whether it is sluggish reaction, no reaction, or normal reaction. So, why this pupillary asymmetry occur? If there is anything there, whether a hematoma or increased cerebral edema, that causes the herniation. The herniation leads to pressure on the third nerve, which is going along this tent. So, the pupillary fiber which is there in the third nerve, that get compressed, and that causes the loss of parasympathetic tone and lead to pupillary dilatation. If that keep on going, then the sympathetic overactivity of the pupil dilate it and make it fix. So, initially the ipsilateral, and then in most of the cases the contralateral pupil can dilate. So, these are the changes which you have to assess while taking a examination of any patient of traumatic brain injury. Glasgow Coma Scale, you might be aware of that. It is very simple, reproducible, and it has 3 components: eye response, motor response, verbal response. Each has a minimum of 1 score, and eye response has maximum of 3, motor has 4, and verbal has 5. So, a total that comes to 15 and a minimum score of 3. If any person is opening his eye spontaneously, that is 3. If not at all, that is 1. In between, if he is responding to the verbal command, then it is 2, and if on pain, then it is 1. So, this is simple, but you should have to learn hard this and try to practice in the trauma department. Verbal response normal is 5. If he is confused, then it is 4. Below that, if it is inappropriate word, slangs, and rest of the things which you won't be hearing from a coherent man, then it is 3. If he is please come in. If he is grunting and making incompressible sounds, then it is 2, and if there is no sound or the patient is intubated, that is taken as 1. Motor response, if he is obeying command, localizing the pain or withdrawal, or there are certain posturing. This is the M2 response, this is the M3 response. They indicate various stages of herniation, various stages of increased ICP. So, that gives a gross idea about the clinical status and the extent of injury in most of the patient, except few incidences like EDH, where there can be a lucid interval. Initially the GCS may be full, but later it deteriorates rapidly. So, this is this Glasgow Coma Scale you should be knowing, and it should be learned by heart. How you assess this responses? So, either you can give you have to give a central pain stimulus. You can give it over the supraorbital nerve or external push, is that will suffice, and by that you assess whether he is localizing the pain. If he is moving his hand up to the site of pain stimulus, then it is localizing. If he is not able to, he is just flexing, this is motor response. If he is extending, this is M2 response. So, this is the way in which you are assessing. The motor response is the most important among the 3, because verbal response, sometimes the patient may have taken some alcohol, or he might be obtunded in influence of drug, or so that can drop from 5 to 1, but motor response, that is associated with the injury inside. So, that is more correlated apart from the in comparison to the eye response and verbal response. Also, there is classification based on this GCS. If there is no loss of consciousness, only some aberration, and the GCS is 15, it is termed as minor head injury. If the GCS is 14 or 15 with or without loss of consciousness, so that is mild head injury. If it comes from 9 to 13, then it is moderate, and when it comes below 8 and below, then 8 to 3, that means then it is severe head injury, and usually severe head injury requires a lot of attention, and the patient, irrespective of the status, is intubated because he cannot secure his airway, he cannot protect his airway. So, even if it is oxygenation is not required, the ventilation and protection of airway is required. So, any patient which is having severe head injury, a GCS of less than 8, they are intubated and observed. Meanwhile, you can also observe whether he is moving both sides of his body equally or not, because if there is some injury over the dominant side, the other side may be having paresis. So, this assessment along with the primary survey keep on going. Cervical spine protection, log roll, cervical collar, and those things, they are continuous throughout the primary and second survey. This is cervical collar, Philadelphia cervical collar, which is usually used and usually provide a good stabilization of neck in most of the patients. This is part of ATLS, you may or may not remember this. So, after that the patient is exposed for the other injuries. There can be a painful area deformity to see for associated fractures and the things. This diagram is important because we often say that a cervical stabilization or spine stabilization needs to be done, but if you can see that at least 3 or preferably 4 people are required to do a proper log roll. Log roll means the patient is turned as such, there is no neck movement, or the neck should be stabilized in a collar. So, you can see minimum 3, preferably 4 are required to provide that log roll. The history needs to be taken once this stabilization procedure is done, or maybe your other team member will continue with the history. So, what are the important points which you will see to ascertain whether whether the patient has injury, head injury, or what could be the severity, what are the various symptoms which will indicate that now you have to be more careful. So, apart from exact time, place, mechanism of injury, the common symptoms or the signs which are seen in a patient of head injury is loss of consciousness and amnesia. If you ask anybody, hey, do you lost your consciousness, so he might say, yeah, I had lost my consciousness, but that also is graded. If the loss of consciousness or the loss of the retrograde amnesia is less than 30 seconds, whether it is less than 5 minutes or whether it is more than 30 minutes. So, accordingly the extent of injury can be predicted in some manner. So, you have not only you have to ask for the loss of consciousness, you have to ask for associated sign, the duration, whether it is associated with severe headache, whether it is associated with nausea and vomiting. And vomiting, 1 or 2 episodes of vomiting may be there, but if the vomiting is recurrent, especially projectile vomiting, that all indicates raised ICP. So, you should be alert if there is recurrent vomiting. Seizures may be present, especially in children, if there is some injury which is leading to cortical irritation such as extradural hemorrhage, cortical subdural hemorrhage, in which the blood over the cortex that irritates the area of cortex and that leads to seizure. Moreover, when there is an increase in ICP, decreased perfusion of brain, that also leads to seizure in many patients. So, you have to ask for the any documented seizure, or once the patient is inside, you start your anti seizure measures as well. Bleeding from ear, nose, throat, maxillofacial injury, injury to chest, abdomen, they also has to be searched for. Apart from that, if you can take down the history of alcohol consumption in older patient, they might be taking some anticoagulant and that can increase the risk of bleeding. Allergy to other drugs, history of pregnancy, because some of the investigation you might want to know the pregnancy status before prescribing those investigation. So, these are the things apart from the general questionnaire you can ask for. Now, once the patient is stabilized, you know a bit of history, you proceed to the secondary survey. In secondary survey, this usually does not take care of the urgent things. All the urgent evaluation and the urgent measures, they usually are covered with the primary survey. Here you can search for subgaleal hematoma or a laceration. Here the first picture shows sign of Battle sign. This is called Battle sign, and this as well as the second picture, this raccoon eye, black eye or panda eye, this signifies the skull base fractures. If there is fracture in the skull base or posterior part of mastoid, then you can find a large bluish discoloration below the ear, and this is raccoon eye, which is because of the subgaleal bleeding or in case of frontal basal skull fractures. CSF rhinorrhea, you have to search for that CSF rhinorrhea, hemotympanum or any bleeding from nose, ear, that needs to be taken care in the later secondary survey. Assessment of GCS and pupillary status, that is a continuous process, because GCS does not only give you the status at one point of time, it also provide an analog so that you can assess that whether the GCS has dropped, and that will help in monitoring the patient whether there is some secondary injury which is progressing. So, GCS assessment and pupillary assessment, that keep on going initially during the primary survey as well as later on also. Now, in the secondary surveys you can also search for gas paresis, which can indicate brainstem dysfunction, cranial nerve examination, whether the lower cranial nerves are involved, whether the patient is able to swallow or there is pooling of secretion. Ophthalmoscope can be used to see the orbital or the globe trauma as well as papilledema, the increased ICP that is reflected in the way of papilledema, retinal detachment and other things, they can also be assessed in the secondary survey. Now, the associated injury of spine, chest, abdomen and other part, they are also searched. Motor and sensory examination, which was not a part of initial primary survey, that needs to be done, that gave a baseline idea that whether the patient has any spinal injury or there is any focal deficit, and in that way a per rectal examination is not indicated in all patients, but if you are suspecting a spinal injury associated with head injury, then to ensure whether it is a complete injury or incomplete injury, rectal examination is usually asked for. Priapism, that is a predictor of severe cord injury, though it is not very common, but if it is there, then it indicates severe spinal cord injury. So, now the initial assessment part is over and we are proceeding towards the investigation part. In investigation, the routine blood test and rest of the thing fast for ruling out abdominal injury, thoracic injury, that keep on going. The main stay of investigation in head injury is CT scan. CT scan, the modality which is used for screening, because it is quick. You can perform CT scan even with sedation. MRI take a lot of time. Moreover, it is difficult to place so many instruments which are magnetic, metallic, tubings and all that thing in the MRI. So, it is neither required nor it provide a better alternative. So, CT scan is the imaging of choice for screening severe head injury patient. This is more important when there is persistent symptom, there are neurological deficits, and for that there are various guidelines which are used in different institutes, and one of this guideline is NICE guideline, which is used in UK National Institute for Healthcare, which says if there is GCS lower than 13, focal neurological deficit, if there is suspected or depressed skull fracture. I had already told you about the recurrent episodes of vomiting and post traumatic seizure. If these are present, then the imaging should be done as early as possible. If there are other indication also, if it is in the geriatric population, patient is on anticoagulant, there is a history of significant trauma, high velocity road traffic accident or a fall from a height of 1 or 2 floors, then also a CT scan can be advised. But these are relative indications. Retrograde amnesia, as I have already told you, that if the loss of consciousness, even if it is more than 30 minutes and the patient has again regained his consciousness, but if that is there, that is also a indication for CT scan, and that can be done within 8 to 24 hours within the trauma center. X-rays are very useful in initially screening cervical spine. If CT is not available, they are also used for screening for pneumothorax, chest injury, and sometime perforations of abdomen in case of penetrating injury. Role of EEG is very limited. They are used in the cases where there is persistent seizure or sometimes in diagnosing the pre-existing neurological condition. So, this part is already covered in last week class, the type of injury based on primary the timing, and that the time of trauma, if there is significant injury, that is called primary brain injury. That can include cortical contusion. The first image you can show, you can see here, these are the cortical contusions. In the second image, you can see the brainstem contusion. This is the fracture. So, these all can be diagnosed with CT, and this leads to injury to the brain immediately. So, these are called primary brain injury. Secondary injury which developed later on by the virtue of cerebral edema, hypoxia, ischemia, or increasing hematomas. You can see the image, there is a subdural hematoma and cerebral edema which is compressing the brain to one side, and if we are not giving pharmacological agents, or sometimes the surgery is required for those patients, then this will keep on going, leading to infarct or a vicious cycle of secondary brain injury or insult. So, now in this part we will go through the pathophysiology of traumatic brain injury. I think biomechanics, the static force, the loading force and the inertia, that all has been covered in the previous class. Is this Monro-Kelly hypothesis that is covered in last class, or I have to cover it? Okay. Anyway, we will then we will see the different management strategy, general measures, specific measures, surgical measures and other things which needs to be done for long term rehabilitation of these patients. So, we go quickly through this pathophysiology. You all know that the normal cerebral blood flow is around about 55 ml per minute in an adult for every 100 gram of brain tissue, and when it drops below 20 milliliter per minute, then it can cause ischemia. So, the body has a autoregulatory mechanism, so that the perfusion, the brain will get its blood supply and oxygen at a permissible level, that is autoregulation. So, how it was done? Let us see. You all know that skull is a closed cavity. So, it has three main components: brain, blood and CSF. So, if one of these increases, then the other has to be compromised. So, it is a nearly incompressible chamber in which these three components have a constant relationship with this. But in case of injury, if there is increase in one of these components, either there is an hematoma or the brain swells up because of the edema, so it leads to autoregulation. The body tries to increase the mean arterial pressure to overcome this. Once the mass or the edema increases the level of autoregulatory mechanism, then that leads to a cyclic cascade. The intracranial pressure that keep on increasing, the perfusion pressure after some time that doesn't able to hold the perfusion, and that leads to hypoxia. Hypoxia again increases the brain edema, and this cycle of inflammation, hypotension, hypoxia, that will go on. So, the main emphasis that should be given to reduce this secondary injury. Before this cascade of cyclic injury starts, we have to stop and do the measure so that the brain can be relaxed. This herniation syndrome, we already have seen this diagram, that it can lead to herniation and compression of third nerve, which leads to pupillary dilatation. Apart from that, if that goes beyond the autoregulatory mechanism, then it also compresses the brainstem. When the brainstem is compressed, there are vasomotor center, there are cardiorespiratory center, they are also compressed, and that leads to a triad which is known as Cushing's triad. That comes very late in the phase of severe head injury, but you should know Cushing's triad, in which the blood pressure increases to maintain the perfusion, but because of the pressure over the brainstem, the bradycardia and respiratory irregularity that are seen. So, this Cushing triad is typical of raised intracranial pressure and this raised intracranial pressure is the main focus of our prevention of secondary injuries. The etiologies of head injury and the later cascade of raised intracranial pressure. What are the causes? Cerebral edema, hyperemia. Hyperemia is direct injury to the cortex and brain. Epidural hematomas, subdural hematomas, intraparenchymal hematoma, foreign body, depressed fracture, they all leads to increase in the injury of the brain cells and can lead to secondary injury as well. Hydrocephalus, though it occurs usually late in the course, but that can also lead to increase in the pressure, because CSF at one stage, if that the ventricle get obstructed from both end and entrapped because of the blood, the absorption of CSF that reduces, so that also add up to the mass effect and increase the ICP. Hypoventilation, the carbon dioxide is the most potent vasodilator in brain. If there is hypercarbia, then vasodilation occur and that leads to venous stasis and edema. Systemic hypertension, venous thrombosis, seizure, that these all has been discussed earlier. Now we come to the management of head injury or increased pressure. So initially, what is ICP? ICP means intracranial pressure. Normally it is around 15 to 20, and our goal is to keep it within the level of less than 20, preferably 20, and the CPP, cerebral perfusion pressure, the level which we want to maintain is 60 to 70 mm of Hg. General measures, that includes the elevating the head end, that will support the venous outflow. The veins should not be obstructed by neck tilt, so keep the neck straight, avoid neck constriction, elevate the head end of bed by 20 to 30 degree, that all will increase in the venous outflow and that will reduce the cerebral edema. Arterial hypotension less than 90 is should be avoided because it reduces the cerebral blood flow. Hypertension also, hypertension if it is going beyond 180, 200, then that can lead to edema, loss of blood brain barrier, and that can lead to increase in the size of contusion and hematoma which are there. So hypertension is also to some extent, after that you should control it. Hypoxia is, I had already told you that carbon dioxide is the most potent vasodilator. So the oxygen saturation should be maintained below 90, and if you are ventilating the patient and monitoring the EtCO2, then it should be in the range of 35 to 40. If you want to reduce further, then it helps in reducing the edema up from the level 30 to 35, that is called hyperventilation. Below this 25 to 30, that is called augmented hyperventilation. So that is not advisable. We try to keep it between 35 to 40. This is PaCO2 of blood, that is round about 40. So 35 to 40 is the goal. There are other specific measures. If the patient is agitated, that also increases the ischemia to brain. So a sedation may be warranted. Also the patient may require ventilation. So the patient are usually sedated, ventilated, and sometimes they are also paralyzed and knocked off in the initial period. Heavy sedation reduces sympathetic tone and the movements of an agitated patient, that can also be controlled. This is also one of a specific measure you if you exactly want to calculate whether there is an increase in the pressure inside, then you can put an intraventricular catheter and monitor the, that is shown in the adjacent figure. You can monitor the intracranial pressure. If it is more than 20, as I already told, then you can give pharmacological agents, draw some CSF. So by this way you can monitor the intracranial pressure as well as drain it also. So it has therapeutic as well as diagnostic both values. You can check the opening pressure. If it is more, you can drain a little bit of CSS, give mannitol, give other decongestant and see whether the ICP is coming down or not. Hyperventilation, this I already had told you that if it is between 35 to 40, it is normal CO2 level in the blood. We can monitor it by PaCO2 or EtCO2. If we want to reduce the edema, reduce the ICP, then we hyperventilate. We increase the number of breaths during ventilation. So that reduces the carbon dioxide. Carbon dioxide reduces in the brain, that leads to vasoconstriction and that reduces the edema. But that is for transient period and for some extent. If you reduce further, then there is ischemia. Below 20, it is not advisable, and aggressive or augmented hyperventilation. Aggressive hyperventilation is not advocated. Augmented hyperventilation for 15, 20 minutes, 30 minutes, that may be done in some specific condition. Hyperosmolar therapy with decongestant. The two commonly used decongestant nowadays is mannitol and 3% normal saline. Mannitol, that is used in a dose of 0.25 to 1 gram per kg per day. It is usually used in bolus. It is used in bolus because the osmotic property that works well with the bolus doses. If you give continuous for 3-4 days, then the blood brain barrier will be disrupted and it won't be providing you the control of ICP. So if mannitol is given, then the plasma volume increases, it increases the tonicity, that is this osmotic mechanism by which it reduces the volume inside the cranial cavity. Apart from this osmotic property, mannitol also has some effect on the rheology of the blood. That means the viscosity of the blood. It improves viscosity, and by other mechanism also it helps in reducing the injury to the brain. So rebound phenomena, it should not be used in patient with acute renal failure, metabolic derangement, and it should be given in the bolus dose rather than a continuous infusion, that has already been told. 3% normal saline is an alternative. It is preferably used in children and can be used in place of mannitol in certain patients where the mannitol is contraindicated. Now last but not the least, surgical indications to lower the intracranial pressure. There are various conditions in which, despite all this pharmacological, general and specific measures, the ICP remain increases, and the condition, the symptoms and the sign, they indicate deteriorating condition of the patient. So one of these is extradural hematoma. You can see there is a biconvex collection of blood. It is compressing the brain, and usually if its volume is 30 cc, in the CT you can easily calculate the volume. If the thickness is more than 15 mm or the midline shift, this is the midline which is going from here from above to down. If it is midline shift is more than 5 mm at the foramen of Monro, then this shows that the patient has increased ICP and he can deteriorate. So this is the indication for surgical removal of that hematoma. This is acute SDH. It is slightly different from the extradural hematoma. It is concavo-convex. It is not biconvex. So, it is associated with a lot of brain edema, and even 10 mm of thickness or a midline shift of 5 mm is taken as a threshold for evacuation of these type of hematomas, because the associated brain injury, that is also very high in this patient. Depressed fracture, we call depressed fracture when the outer table of the skull goes beyond the inner table. So, that is depressed fracture. If it is compound depressed fracture associated with a lot of foreign body and contamination from the site of injury, then that is also indication of surgery. The bone fragments may be inside the brain that are removed. There are sometimes CSF leak because of the dural injury which is beneath this fracture. So, that dural leak needs to be sutured. So, these are the indication where you operate a patient in skull fracture also. Surgery is indicated whenever there is a progressive neurological deterioration, increase in ICP, and the CT scan or whatever imaging you are using shows a increase in the size of the mass or increased intracranial pressure. Patient of GCS lower than 6 to 8 or those having midline shift of greater than 5 mm, they sometimes undergo decompressive craniotomy where the skull is removed so that the expanding brain has some space till the edema reduces. That also being done. Now, there are certain controversies or certain points which are also associated with head injury. Steroids which are used very frequently in tumor, they are of very limited use in head injury. Rather, steroids are almost not used in head injury unless they are associated with cranial nerve injuries. Cranial nerve injuries, if there is injury to optic nerve or there is injury to facial canal, facial nerve, then they can be used as pulse therapy. If there is brainstem injury, brainstem edema in that cases, and if there is cervical spine injury in the initial phases, there are certain studies which have shown that the use of steroid may be helpful, but otherwise steroids are usually not recommended in cases of head injury. Prophylactic hypothermia, that is also a gray area, and if hypothermia needs to be started, that should be early. A jacket is tied around the body of the patient and cold saline that is infused throughout the jacket, and a temperature in that jacket is maintained between 4 to 8 degree or so that the metabolic rate will be less and the patient will be benefited. But there are certain side effect of all that hypothermia is also there because of the muscle the shivering. You need to paralyze the patient. If you keep a patient in 4 to 8 degree of temperature of cold saline, so there is a lot of shivering of the muscle. So you need to paralyze the patient, and for that you have to intubate also. So this prophylactic hypothermia, that is also not used in most of the patient, only in selected patient if they present early, or it is used for only initial 2 or 3 days, not more than that. Seizure prophylaxis, that is recommended for prevention of early seizure in initial 7 days, but after that, unless there is cortical hematomas, contusion or major brain injury, brain parenchyma injury or intraventricular or intraparenchymal injury, that is not recommended beyond 7 weeks. The most common anti-epileptic which are used are phenytoin, valproate, and nowadays levetiracetam. These are the common drugs which are used. So pharmacological agents, they should be known to you, which are used in head injury, like mannitol, hyperosmolar sodium, phenytoin, valproate, levetiracetam. This needs to be known to you, and various questions in different interviews and competitive exam are based on that. So you should be learning about those also. Enteral nutrition, that is for the late rehabilitation and for prevention of further injury. It should be preferably reinstituted within 72 hours, and after once the patient start mobilizing, has some improvement, enteral and oral should be preferred. So that's it. That's all about the assessment and investigation management and the various measures which are used in managing head injury. If you have any questions, and you can ask. If anything is not clear, then clear, or you are all sleeping. Anyway, I have covered the topic slightly in detail, but that's okay. If you can learn GCS, various agent which is used in controlling the method of ATLS, and if you can learn the examination, primary survey, secondary survey, triaging, then it's enough for now. Okay, fine. Somebody will come and take the attendance.